Okay, so thank you all for joining us for this week's Miami Global Brain Tumor Symposium. Really excited for this week's session. Just a quick introduction before we start. My name is Michael Ivan. I'm one of the neurosurgeons at the University of Miami, focusing on skull base and brain tumors, and the director of our research program here on brain tumors. I'm joined today by my colleagues, Dr. Morcos, who's professor and co-chairman of our department here at University of Miami, and also the director of the skull base and cerebral vascular program. Dr. Komatar is professor and the residency program director of our program here at University of Miami, as well as the director of surgical neuro-oncology, and also Dr. Benjamin, who's assistant professor and brain tumor skull base specialist, newest recruit and director of our Kane skull base laboratory, who's also joining us. Each week we put on these seminars for across the world. Anybody interested in neurosurgery, and this cannot be done without our amazing administration. Christina, Ingrid, Roberto, Ignacio, all are instrumental into making this such a big success. And so many thanks to them. If you want to know more about our symposiums, you could always follow us on social media. We're active on Twitter, Instagram, also on YouTube, where all of our videos are posted after our seminars. If you want to sign up for some of the other symposiums we have, cerebrovascular, skull-based symposiums, we have a resident symposium, grand round symposiums, you could always go to our website, neurosurgery.med.miami.edu. Quick preview into what's upcoming as far as our symposiums. Tomorrow we have continuing with the endoscopic intranasal kind of genre. We have a great debate between Dr. Pravadello and Dr. Schroeder on anterior skull-based meningiomas, endoscopic versus transcranial approaches, with our great panelists seen down below. And then next week on our Miami Global Brain Tumor Symposium, we'll be welcoming Dr. Cohen Goodall, talking about approaches to pineal region tumors. I'm sure you know, he's the CEO of the Neurosurgical Atlas. This is one of the great resources for neurosurgeons across the world, talking about approaches and techniques. So we're very happy that he'll be joining us next week. Quick housekeeping. So please use the Q&A button as much as you can on the bottom. We encourage you to ask questions. We'll get to them throughout the talk and definitely in between the speakers. We don't offer CME, but you will get an email confirmation documenting your participation. And please be sure to like, follow, and share our videos and upcoming symposiums so that we can continue to grow and share everybody's knowledge with anybody interested in neurosurgery. So this week we have a great set of panelists coming from across the country. First and foremost, Dr. Zada, Associate Professor and Residency Program Director at USC. He's also director of their endoscopic skull-based program and their Pituitary Center and Radiosurgery Center. You could follow him at Dr. Zada on Twitter. Dr. Karina Levine, who's an assistant professor of ENT here at the University of Miami, one of my colleagues, and very lucky to have her to do all of our complex endoscopic intranasal approaches with, as well as with her colleagues, Dr. Sargi. Dr. Beaumont, coming from us, also from the West Coast, from UCSD, assistant professor of neurosurgery and a specialist in skull-based and minimally invasive cranial surgery. And Dr. Hamp, who just moved to Westchester Medical Center, also a specialist in minimally invasive and skull-based surgery. They'll all be presenting cases at the end of tonight's session. But most importantly, we have a fantastic keynote speaker here today, joining us late night, all the way from Italy, Dr. Cavallo. Thank you so much for joining us. He's an associate professor of their neurosurgery department in Naples, Italy. He's authored more than 300 articles, of which most of them have to deal with endoscopic and nasal approaches. Obviously a huge passion of him. He's really world recognized, mentored by Dr. Capobianca. He did time fellowship both in the US and Italy, author to multiple books as seen here above. And really, their center in Naples has been at the forefront of endoscopic endonasal surgery ever since the beginning for more than 30 years. And we've learned so much from them and their group. And we're very excited to have him talk to us tonight about his strategies dealing with craniopharyngiomas and pituitary tumors. So Dr. Cavallo, thank you so much for joining us tonight.
Thank you, Michael. Thank you very much for your introduction. It's for me a true privilege to have this lecture with you. Now I'll try to share the presentation. Okay. Please tell me if you can see the screen now.
You're in navigator mode. You need to play it.
Okay.
There we go. Okay.
Is it okay?
That looks good.
It's good. Okay. So thanks again for this invitation. It's really a true privilege for me to share with you the experience of our group in Naples, as you say, guided by Professor Paolo Cappabianco, who is my mentor and is the man with which I had the privilege to share this journey over the last 23 years. So I will start the presentation speaking about craniopharyngioma. As Dr. Cushing said a lot of years ago, it was defined as the most forbidding of the intracranial tumors. And he was absolutely right, because if you see beside the surgical removal, the other options that were used, some of them are still used, you can understand the complexity of this disease. And if you look the surgery, over the year has been proposed a lot of transcranial approach through different corridors. And beside transcranial route, since the beginning, also the transsphenoidal route was considered. But the transsphenoidal route was considered just for one subtype of craniopharyngioma, which are the infradiaphragmatic craniopharyngioma. And the indication for this kind of craniopharyngioma was quite clear since the 60s with Gérard Gouillot and Jules Hardy, because just those craniopharyngioma which were extended inside the pituitary fossa without any involvement of the subarachnoid space were considered amenable of the transsphenoidal approach. And you see here the different variation of the transsphenoidal route that have been proposed over the year, from the transrhinoseptal to the sublabial to the direct endonasal microsurgical approach, up to the more recent endoscopic endonasal approach. And if you look what happened when you approach infradiaphragmatic craniopharyngioma with the transsphenoidal route, if you look this picture, you have the impression that you are removing a tumor like a pituitary adenoma. It's absolutely similar to pituitary surgery. You know that you are protected by diaphragma, by the diaphragma and by the suprasellar system. So with the curettage suction, you can easily debark and remove this tumor, and thanks to the endoscope, you can navigate all around the diaphragma. You can do some tumor removal in some hidden corner, but anyway, you always have the diaphragma which protect you. So it's a quite safe surgery, fast surgery. And you see at the end is exactly the same picture you have when you remove a pituitary adenoma. And also the results are quite good. And if you look also that these infradiaphragmatic craniopharyngioma quite often are cystic, so they are even more easy to remove, and especially when you have this kind of tumor in pediatric population, the results are really satisfactory. You see this is some cystic craniopharyngioma, and the results are really good. And the good thing is that even if this kind of craniopharyngioma can recur, of course, like all the craniopharyngioma, they usually recur below the level of the diaphragma cell. So you can redo surgery 1, 2, 3 times, and especially in pediatric patients, you can avoid radiotherapy. In this patient, you can delay radiotherapy, you can let them grow up. So at the end, the prognosis of this subtype of craniopharyngioma at the end is really quite good. But of course, the situation is completely different when you have to deal with the supradiaphragmatic craniopharyngioma, which are more frequent, which are more complex, and that this kind of tumor really have been approached through a lot of corridors, transcranial corridors. But of course, all you know knows that today is possible to approach this tumor even with the endoscopic approach. Even if, to be honest, even with the microscope, thanks to Martin Weiss, Oldfield, the other pioneers, Ed Lowe's, they have tried to remove some of this supradiaphragmatic craniopharyngioma even with the microscope through the transsphenoidal route. But of course, it was thanks to the Pittsburgh group with Amin Kassam, with Karao, that they some way pushed the boundary of this kind of approach. And of course, you have to be a little bit more invasive through the nose because you have to resect some nasal structure. But doing this, you can really create a sort of craniotomy above the level of the cell, and this gives you the opportunity to have a nice view to the supracellular neurovascular structure through an inferior perspective. And this is an example of what happens when you deal with the supradiaphragmatic craniopharyngioma within the nasal root. You see, you open the dura, you suddenly see the tumor, and with this approach is really good the possibility you have to work below and behind the chiasm. So it's really nice the view you have, especially on the retrocellular space, and you have the possibility to recognize the limit of the tumor with the neurovascular structure. For example, here you can see the limit with the tumor capsule with the floor of the third ventricle. So no blind traction. You always do surgical maneuver under direct visualization. You can even work above the level of the chiasm. Here you can see the lateral wall of the third ventricle, the limit of the tumor. So really you have a nice view on this critical area. Of course, the principle of tumor removal are the same you use during the transcranial approach, so never en bloc resection, bimanual, blunt and sharp dissection, and try to preserve all the perforating vessel you have to deal with. And this is an example. This case is has been made with a 4K camera. The quality and the resolution of the picture is good, but you know, with the 4K camera, the color are not so good as well. But anyway, you see this teeny perforating vessel that has to be preserved. And today, with this high resolution camera, is possible to do this micro dissection. You see at the end to save all these teeny perforating vessels. You see, this is our series. We have treated 124 craniopharyngioma. Most of them has been treated through extended approach. But in both series, standard and extended procedure, as you can see, we have operated recurrences because you always have recurrences coming from transcranial approach, from transsphenoidal approach. But the good thing is that you can use this approach even in pediatric population, even in young patients. The youngest patient we have operated was 7 years old, but there are series in which have been treated even patients at the age of 2 or 3 years. And you can treat both infra or supradiaphragmatic pediatric cranopharyngioma. And of course, the corridor is more narrow. Sometimes you have to use thinner endoscope, 2.7 millimeter endoscope instead of 4 millimeter endoscope, but with the proper instrument, you can replicate the same microsurgical attitude you have in adult patients. You see how you can preserve superior hypophyseal artery, pituitary stalk, even if you have to know that one thing is preserve anatomically the stalk, one thing to preserve its function. But anyway, the result, and is something that today is well known, are good, especially on visual function, and also with this approach you can avoid some of the problem we had in the past with the behavior changes, mental problems, and so on. Of course, you have to respect some criteria selection when you plan this approach. Above all, you always have to check on MRI the chiasm position, the position of the stalk, paracellular extension. Of course, not all the craniopharyngioma can be managed through the endonasal route. And when you approach this tumor from below, this is really a nice classification proposed by Amin Kassam, and is based on the position of pituitary stalk, so that you can treat tumor which are anterior to the stalk, inside the stalk, behind the stalk, and we have treated all this kind of tumor with the endonasal route. And what was clear since the beginning is that the result of on visual function are very good, with also good gross total removal, and we paid a high price due to high risk of post-op CSF leak, but you know, today this rate is decreasing significantly. And we also noticed that with this approach it's possible to remove tumor also growing inside the third ventricle. This was at the beginning quite strange, but if you look, this is not so strange, because when you have a tumor growing inside the third ventricle, the tumor itself pushes down the floor of the third ventricular cavity, so that the ventricular cavity became more close to the supracellular space, so that following the extension of the tumor inside the third ventricle, it's possible to remove it. We study anatomically this region, and we realized that it's possible to explore the bigger part of the third ventricular cavity with the endoscope. So from infundibular to foraminal to mesencephalic area. And what is very critical when you enter the third ventricular chamber through the nose is to recognize some important anatomical landmark, above all the mammillary body along the floor of the third ventricle. And this is a collection of some picture we had during our cases. You see how different it can appear the ventricular cavity, but what is very important during surgery is to recognize this landmark along the floor. So always try to recognize the prominence of mammillary body, which as you can see sometimes can be very close to the dorsum cellae, some other time it can be far from the dorsum cellae. In other case, the floor can be interrupted, and you see here this PCOM inside the surgical field. So very important to explore this region. I just want to show you this case to show how it is possible to dissect, for example, the capsule of the tumor inside the third ventricular chamber. We usually start from the upper part. We dissect from the inferior surface of the chiasm the tumor capsule, and then we gradually move down along the lateral wall of the ventricular chamber, and only at the end we dissect the inferior part of the tumor, always checking the prominence of mammillary body. You see here at the end this prominence and the ventricular cavity free from the tumor. And this is a collection of some tumor we have removed in coronal sagittal plane, pre and post-op. And another case, you see very large cystic intraventricular tumor in a young boy, pre, post-op, also on axial. You see on flare, no brain manipulation, no damage. And in this other case, and the good thing is with this cystic tumor that even when you leave some remnants of the capsule, you can use radiotherapy on that capsule, because radiotherapy seems to be quite effective on the cystic wall. And also you can use this approach on recurrent craniopharyngioma. For example, this patient has been already operated transcranially, had Ohlmeyer reservoir, was irradiated. So we suppose that this patient had a lot of scars around this tumor. So this is our strategy. We try to change the route, so to use a virgin route coming from below. So this time we used an endonasal route, but and we were able to remove at least subtotally this tumor. But it happened even with the endoscopic approach. I mean, you can have a recurrent tumor that you have already operated endonasally, like this case. This patient has been operated endonasally, here recurs. This is another patient operated endonasally and recurs. In this case, was used the transcranial approach instead of doing again an endonasal route and have to deal with the scars of the previous approach. And also in some cases we have used the Ohlmeyer reservoir with the inserted through a ventricular approach for some isolated cysts growing inside the third ventricular cavity. So you have to adapt your surgical strategy according to the extension of the tumor, but the true problem of craniopharyngioma that whatever is the approach that you use, they sometimes recur. We still don't know why some craniopharyngioma recur more frequently than others. We are trying to understand this, and for example, we know, for example, that the presence of beta-catenin expression exposed to increased risk of recurrences in adamantinomatous craniopharyngioma, like for example, in papillary craniopharyngioma, the presence of BRAF mutation open a new windows, for example, to immunotherapy. But this is just a preliminary experience. There is still a lot of work to do, and it's very interesting also this article concerning radiomics, because some group are trying to also predict the presence of BRAF mutation by radiomics. So there is still a lot of work to do on craniopharyngioma, and again the endoscopic approach is just one instrument in the armamentarium of all the possibility we have to manage this kind of tumor. And then we can move to pituitary adenomas. I would like to start with this sentence from Ed Laws, because the vast majority of pituitary adenomas can be treated through transsphenoidal route. Was this years ago with the microsurgical transsphenoidal approach, is the same, of course, with the endoscopic endonasal approach. All these approaches were effective in managing pituitary adenomas, and of course, the endoscopic approach permits as well to remove this tumor. The history of the endoscopic approach starts thanks to this guy, to Hedong Joe, who in 1996 in Pittsburgh, together with Rick Carrau, started and standardized this approach. And that experience was followed by Professor Cappabianca and De Divitis in 1997. And it's interesting because 1997 was the same year in which I entered the residency program in Naples. So I was, to be honest, very lucky, because I had the opportunity to see since the beginning the evolution of this new technique, and also to see all the effort that are required to start a new technique. And this is the setup at that time. First procedure were made using this ureteroscope. It was 32 centimeters in length, with a very bad quality of image. As you can see, we used the C-arm fluoroscopy, we used the holder, and you see on the screen the quality of the picture. So it's really hard to understand how it was possible to not stop this procedure with this quality of picture. But then in the next year, the overall quality of the picture improved, and this thanks to big technology change concerning either the camera, which moved from mono CCD to 3 CCD, and also light source, from halogen light source to xenon light source. You see here, but then we moved to 3D endoscope, and we have explored all the new advances in the technology field. You see here Dr. Solari using 3D endoscope, but we have used also OLED screen Visor, which are good for teaching but not so good for surgery, and also of course the new 4K camera. And all of you know the big benefit we had with the endoscope is the possibility to switch from a panoramic view inside the sphenical sinus to a close-up view inside the cell. This is probably the best advantage we had with the endoscope. Of course, the principle of transsphenoidal approach remained the same, nothing has changed, but what we can do today with the endoscope? Of course, we can treat what we defined the conventional pituitary adenomas. It means the same pituitary tumor we were treating even also with the microscope years ago, from a small intracellular pituitary to large, even to giant pituitary adenoma. But we also were able to extend the boundary of this corridor, for example, extending the approach to the cavernous sinus. And all of you know how it is easy to visualize the medial wall of the cavernous sinus, and then with the suction cannula to do suction inside the cavernous sinus and remove and debulk the part of the tumor growing inside the cavernous sinus. But it is also possible in selected cases to go laterally to the carotid artery, even if this approach is indicated very rarely. But anyway, in selected cases, it's also possible to work laterally to carotid artery through transpterygoid approach and to remove some part of the tumor growing in that area. But with the endoscope, through extended approach, was also possible to treat some unconventional pituitary adenoma. What are these unconventional pituitary adenoma? Is another subset of pituitary tumor with different characteristics. I mean, some of these were considered contraindication to the transsphenoidal route some years ago, like dumbbell-shaped pituitary adenoma with a neurovascular encasement, pituitary adenoma extending inside the third ventricle. And you see, these are not routine cases. These are not daily cases. And some of these cases were treated before with the transcranial approach. And in this case, what you have to do is what you do usually with the extended approach. You have to do an extracapsular dissection. And you can do this if you open the plano. I want to show you just two examples. You see this quite large and irregular pituitary adenoma. You start to remove this pituitary tumor like usually, but what happens with this kind of tumor? You have a prolapse of the cister with a lot of tumor still inside. So you have to go above the level of diaphragm. You have to remove the soft part of the tumor, and then you have to do a procedure like you do transcranial. You have to try a plane of the capsule with a neurovascular structure, try to preserve all the teeny vessel which supply the chiasm and the pituitary stalk. You see here the dissection of the capsule from a compressed chiasm, and the surgery in this kind of approach is a little bit more complex because usually pituitary bleeds more than craniopharyngioma, even more than meningioma. So you have to wash a lot during the surgery, and then we saw the reconstruction with the fat and flap, but the results are quite good. This is another case which seems to be like a normal pituitary adenoma, unless you look this. You have a part of the tumor which was growing inside the third ventricle. So even in this case, you cannot remove through a single approach. You start like normal pituitary surgery, but then you have to go above the diaphragma cell because you don't have the prolapse of the suprasellar cistern. And this kind of surgery is, of course, more complex. You have to find the chiasm, you have to look the vessel, and this is this type of growth of the tumor was very strange because the tumor was growing through lamina terminalis inside the third ventricle. Very strange pattern of growth tumor. And you see also the A2 were distorted, all the neurovascular structure were distorted by this tumor. So, but the coagulation of diaphragm, also in this case at the end, was possible to have a good tumor removal. But of course, extended approach for pituitary tumor are used very rarely. These unconventional adenoma represent no more than 5% of the cases. And also, if we look, the rate of tumor removal is not so high. And also, if you look at the complication in this kind of approach is, of course, higher if we compare to standard pituitary surgery. You see more CSF leak, more vasospasm. I want to show you, for example, one case of vasospasm. You see quite not large pituitary adenoma, quite good tumor removal with preservation of the neurovascular structure. And this patient, a few days after surgery, had some vasospasm. We had to use a lot of nimodipine infusion to repeat this procedure 2-3 times until you resolve the vasospasm with just minimal problem in the late post-op. And another thing, you need an adequate set of surgical instruments because especially for those tumors growing inside the third ventricle, you need a longer suture cannula, longer dissection instrument because otherwise, especially in patients with long nose, your instrument will not be able to reach the distal part of your surgical field. Also important in this tumor, especially when you have to use an extended approach for pituitary adenoma, it's good to have some reliable information about the consistency of this tumor, because especially if this tumor is soft, the surgical removal, of course, is much easier, and the radiomics is giving us good information. And I would like to conclude this presentation speaking about reconstruction because he was considered a sort of Achilles heel of the technique, and over the last 20 years we have used a lot of techniques, materials, and probably if you ask to 10 surgeons the technique they used to reconstruct the skull base, you will receive at least 11 answers. And really we had a lot of mistakes, and what we are using now is the synthesis of all our mistakes and all our attempt we have to reconstruct skull base. And this is the 3F technique, which is made just by fat, flap, and flesh. So only autologous material, and it's also important the way we use the fat, because the fat is used not inside, not outside, but across the skull base defect, like a cork stopper. This was for us the best way to seal all the corner, all the border of the skull base defect, especially when you have to open widely at the level of the optocarotid recess. This seems to be the easy way to seal this corner. So we don't use anymore any multi-layer reconstruction, no gasket seal, no sphenoid sinus balloon. We even don't use any more lumbar drainage. And the second F is for flap. Of course, all of us recognize the important role of a pedicle nasoseptal flap for skull-base reconstruction. So two simple things, fat and flap, and these are the only two things we use, the only two materials, two autologous material we use to close the skull-base defect. And then flash. Flash is for fast mobilization of the patient. At the beginning of our experience, it's quite common to say that after this kind of approach, the patient has to stay supine in the bed because the pneumoencephalus, because all the risk related to the increase of pneumoencephalus and so on. But that was really a bad mistake, because what we learned over here is that this patient absolutely has not to stay supine in the bed after surgery. It's very important to elevate the head at least 45, 60 degrees in the bed as soon as possible, and to mobilize the patient within 1-2 days. Even if they have pneumoencephalus, this is not tensive pneumoencephalus, but it's the if you mobilize early this patient from the bed, the pressure of the brain over the skull base defect will be reduced considerably. Last video before the conclusion, just to show that even with the large, very large skull base defect, this is a case of chondrosarcoma from, and the opening was from CDJ up to the planum sphenoidale. And I want just to show you how much fat you can use inside to fill the surgical cavity. So you remove the tumor and you fill the surgical field with the fat. You don't have the risk to do overpacking, because as you can see, the intracranial pressure will push out the excess of fat. And once you have do that, just a thin layer of fibrin glue, and then the entire surface is covered with the nasoseptal flap. But what happened with this fat that we put inside? You see this MRI at 3 months, it's a lot, but look, after 1 year, half of it has been resolved. So this is something we are evaluating now. What is the degree of reabsorption of the fat over the time? But the result on post-op CSF leak seems to be really promising. We really decrease a lot the rate of post-op CSF leak, which now is around 4%. So absolutely not so bad. I think that I've finished with these slides, and thank you again for your attention.
Thank you so much. That was really phenomenal. We have a couple questions that came in here. So one was earlier, for craniopharyngioma, is there anything that you do differently if it's a recurrent craniopharyngioma? Obviously, there's post radiation, post first surgery. Are you more likely not to do it endoscopically, or are you more likely to do a larger opening? Anything techniques that you use for recurrence?
For recurrence, usually the strategy is to try to avoid the same corridor twice. If you have operated endonasally, maybe it's better to do transcranially, and vice versa.
Okay. And for the smaller openings, when you're using fat, obviously larger openings, the chiasm is pushed very high, and so it's easier to kind of put the fat in there. But for smaller openings, you're always worried when you put fat in there, are you compressing the nerves? Yes. What are your strategies for the smaller openings to understand, how much fat you could place?
Usually we put not a single piece of fat, but different piece of fat, even below, above the chiasm, laterally. But as I said, usually if you don't use a gasket seal technique, you avoid the overpacking because the brain pulsation push outside the excess of fat. This is a protective technique, I would say, for the intradural space.
And when you take the fat harvested, is it something you do at the beginning of the case, or do you wait till the last minute and then last minute?
Last, because we want to have fresh fat.
Got it. Okay, great. Any questions from the panelists before we start with Dr. Zada?
Yeah, Mike, can I ask Luigi a quick question?
Please.
Luigi, thank you so much. Listen, I'm sure we should all also remember 1960, not remember, but Gérard Guillot really should be credited with the first pure endoscopic approach. It's amazing. Is it 1962? And then nobody does anything about it till Joe comes along 35 years later.
Yeah, absolutely true.
Yeah.
I had the original video and it was really amazing to look him work at the endoscope. Really amazing.
Yeah. I have it too. It is amazing.
It's an amazing video through the speculum.
Yes, through the speculum, absolutely.
Assisted, yeah.
It's Tom Beaumont here. Just looking at that early video that you showed, I mean, the image quality that we're all so used to now, I cannot imagine pushing the field forward back in the day when that's the kind of detail you had available.
Yes, that's really amazing. That's really amazing. Unpredictable. What happened, you know, when you use a new corridor, you cannot predict what technology will do for that approach.
Absolutely.
It was just a small windows when we entered the cellar with the endoscope, and that small windows became a door. So not predictable.
Luigi, can you, I don't know if you still remember, I guess it was the beginning of your residency, how long, like how many cases at the beginning the capability to like frustrated and bring the microscope in and continue the case with the microscope? I would imagine.
It was a funny story because I remember Professor Cappabianco was in the room starting with the endoscope, and there was behind Professor De Divitis ready with the microscope to switch the procedure. But Professor De Divitis was very smart to be patient and wait. And even if first procedure took even 3-4 hours to remove a pituitary adenoma with the endoscope, 3-4 hours.
Wow.
Yeah. It was absolutely not easy, but things changed over the time.
Yeah, amazing how things have changed, and many of those changes have been thanks to your group. So thank you again, Dr. Zada. You want to pull up your talk?
Sure, happy to. So, oh, it's not doing this again. It's odd. Let me just quit this and I'll restart it. Okay. See if this works. There we go. So I'm going to just show two relatively quick cases here. I want to thank you guys for having me, Dr. Ivan, Dr. Morkos, Dr. Komatar, Dr. Benjamin, and the panelists. And I want to thank Professor Cavallo and Cappabianco also. I was very lucky. I got to spend a few months in Napoli just about a decade ago. So about 3 months with their group and watch how they do things in the Federico Duo Hospital there. And it was, for me, a transformational experience. So very thankful to them. So this is I was asked to present some challenging cases. This was a young man, 22-year-old, presented with significant vision loss. He was almost no light perception in his left eye and significant vision loss in the right eye with a bitemporal hemianopsia, hypopituitarism, DI. You can see the morphology of the tumor, normal pituitary gland, and then also a huge retrocellular intraventricular component here. So very similar approach to what Luigi showed. And let's go through the video here. So we would do a transtuberculum, transplanum approach, and also remove any bone along the dorsum sella as well to give us access to the retrocellar region. And here you can see some of that opening. Always use a Doppler routinely. And here's our supracellar window. We're now cauterizing the superior intercavernous sinus. In this case, he already had panhypopituitarism, so we made a decision to sacrifice the entire gland and stalk here. So we'll start with some internal tumor debulking. And then we're working under the normal gland to really clean out the sella here. We're working superiorly to identify the chiasm and dissect the tumor away from the chiasm. And then working under the tumor after bony removal to really carefully dissect the tumor away from the basilar apex, thalamal perforating vessels, PCAs. And then as you work laterally, you have to be very mindful of the oculomotor nerve and PCOM. And I think that's one of the most challenging aspects of craniopharyngioma surgery are the PCOMs and the thalamal perforators. And then finally working on the intraventricular component, peeling the capsule down away from the third ventricle and delivering the tumor here. So we would do a similar reconstruction technique here. Here's our inspection of the cavity. You can see that into the third ventricle here. Obliterate any dead space with fat is something I also like doing. I will do a dural reconstruction with fascia lata. And in this case, we used just a flap over it, not a gasket seal technique. So similar to what Professor Cavallo showed, except I'll also use a dural reconstruction. We've tried the FF approach, and I liked it a lot more recently without a fascial barrier, but in this case, we did use one. And you can see the resection there. I actually just saw this patient again yesterday. He's about a year and change out, and what you're seeing is the fat graft here, and this is the post-op fat suppressed scan, and he's doing great, vision's improved, still panhypopit, of course, and no radiation afterwards. So just a quick switch to pituitary tumors. You heard about a lot of this. I agree with Gigi that most pituitary tumors do not require extended approaches. That's because they're often soft enough to deliver from the suprasellar cistern. You can see the arachnoid come down into the sella. And then you can use an angled endoscope to reach up and remove additional tumor and allow the arachnoid to prolapse down into the sella, which is what you want to see. When you see extension over the tuberculum sella into the anterior cranial fossa or lateral extension, that might be an indication. So here's just an example case. 55-year-old man with vision loss, also a right third nerve palsy with, you can see tumor extension into the oculomotor cistern there. So this would be an extended case for us. I always start with just a sellar exposure because I want to see how soft the tumor is first. And pituitary tumor, much like meningioma tumors, the consistency is absolutely critical. And we've shown in a couple papers that it's associated with outcomes as well. So now we've done our transtuberculum approach, and you can see that even though it's a pituitary tumor, you can have dense capsular or pseudocapsular adhesions. And so we're dissecting it away from the carotid and optic chiasm now. And this was very adherent to the chiasm. We even decided to leave a very thin rim there. And then our reconstruction in this case was with alloderm and a gasket seal. And then a flap over that. And this patient did fantastically dramatic visual improvement and third nerve palsy improvement with gland preservation. You can see the gland here pushed back, and here's the plate there. And so he's doing really well to date as well. And there's the post-op scan. So that's all I have for my two quick cases, very similar to some of what you saw with Dr. Cavallo. And again, thanks for having me very much.
Yeah, those are great cases, Gabby. Nice job as always. A couple questions here for both you and Dr. Cavallo. So for large pituitaries, when do you decide for the intracapsular versus extracapsular resection, and when is your threshold for expanding it like you did for the tuberculum? Is it purely just based on how firm it is, or is there other features as well?
Yeah, well, for giant ones, I don't really believe in a full. I think you have to do tumor debulking to even consider an extracapsular resection. For a mid-sized tumor, I think firmness is really critical about the way it's resected. For soft tumors, they can be curetted and suction, but I find myself doing the extracapsular approaches on the more firm adenomas in general.
Yeah, absolutely true.
For the craniopharyngioma you showed, I saw there's a lot of calcification within it. How much do you let the preoperative CT kind of determine if it's a good endoscopic case versus not?
I find that you can still sufficiently debulk the soft tissue components or cystic components, even when there are calcifications. So unless it looks just really hyperdense, like bone almost, and most of the tumor appears that way, I do almost all craniopharyngiomas endonasally now, as I think a lot of people do. I'd love to hear what Dr. Cavallo does with those.
Yeah, all craniopharyngioma are studied also with the CT scan, but of course calcification is not a contraindication for the endonasal route.
Gabby, quickly, it's Tom Beaumont here. What about primarily retroinfundibular intraventricular lesions? They're kind of wrapped around and extending superiorly. Do you do those through a tube or transcranially first?
It depends how high they extend, but I feel like you can still get to a lot of those. Yeah, but if there's a huge intraventricular component, I'll do most of those with a tube, usually a brain path port or something like that, to resect that lateral ventricular component. Or if it's purely third ventricular, then sometimes we'll do that as well.
Yeah, I agree.
Okay, great. So let's go on to Dr. Levine. You want to go next?
Stop sharing here.
Okay. Are you able to see my computer?
Not yet. It's still in limbo.
What about now?
Yeah, now we can see it.
Great. So I was asked to talk a little bit about reconstruction, and I think we use a slightly different technique. So I'll just show another range of options, and I'll do it with a case. This is a resection repair of a giant pituitary adenoma. And just to kind of introduce the technique that I have been taught, and I think that there are many ways to skin a cat, and so there are a lot of good ways to do things. This is the one that I use the most, is the INLAY ONLAY technique, which my partner Roy Cassiano really kind of perfected. So essentially what we end up doing is we use alloderm pretty much almost exclusively, and we'll drape it in an INLAY ONLAY fashion. We'll put in a little bit of Surgis foam and Surgisil and gel foam plug, and that will fill this entire area. So you're essentially filling the defect, and you're using the brain to be able to kind of push this area on there. And so it ends up looking something like this schematic. And we use that not only for our pituitary reconstructions, but actually for our entire large anterior skull base reconstructions as well. So this is a case of a 53-year-old female who presented with some nasal obstruction and incident a larging after she had this motor vehicle accident with head trauma, and she had decreased ability to communicate after the accident, and she had some decreased visual fields. And so this is her imaging, and I'll just run through very quickly her MRI, and so you can just see the extent of this tumor, which fills the nasal cavity, and then of course extends back into not only the sphenoid, but also into the cellular and extending up and pushing on the optic chiasm. So this is her video, and this is a long video, so I'm going to jump around a little bit, but just to give you guys an idea of what we did. So you can see that this is a very large tumor. It's filling the right side of the nasal cavity. And of course, the first thing that we wanted to do was confirm that this really was what we expected it to be. And so what we ended up doing is taking some biopsies, sending that down for frozen while we debulked the rest of the tumor and got ourselves ready to go. And it did come back obviously as pituitary adenoma. I wouldn't be presenting it in this forum, but we did end up debulking all of this. So this gives you kind of a look at each of the different sides. If we skip forward a little bit, you can see that we're really opening up that nasal cavity and just getting a really good view of everything. We try to get access to our sphenoid, we open up our maxillary and open up our ethmoid because we really need to remove all that tumor. And you can see that your sphenoid on the side is just very much blocked by all of the tumor pushing over onto the septum. So we ended up doing our posterior septectomy, realizing that there is tumor involvement and understanding that that actually eroded through both sides, and that really blew the ability to use nasal septal flaps in this case. So we did take a large septal mucosal graft and held on to that in case we needed it at the end so that we could do the rest of our septoplasty. But both of our pedicles for our flaps were involved with the tumor that had essentially eroded through. So you can see us debulking that mass. And then as we kind of move forward, you can see that we're clearing out some of the ethmoid cells. We're getting a much larger opening so that then we can really start working around this large tumor. And then of course we've gotten it all out of the sinonasal cavity. So here's that posterior septectomy that we've created between both of the sides. And now you can see that we're just starting to see if we can start leveraging this relatively rubbery tumor out of the sphenoid cavity. So what you're looking at is tumor that's located within the sphenoid cavity. And we're just prying that area out, trying to see if we can release some of that. And it was relatively adherent in that area. You can see that there's some parts of it that have a more liquidy appearance, but it was pretty rubberly and firm. And so then if we move forward a little bit, we'll show you a little bit of kind of the orientation of where you're located if you're not as familiar. So the ethmoid is above you, the maxillary to the side, and the sphenoid where we're clearing out all of this tumor. And then we pretty much move forward pretty quickly and start moving on to our four-handed technique. And so at this point, once we've really gotten an idea that we've got a good area around the tumor, we're able to work, then we'll bring in and have our neurosurgeons get started in helping us, trying to remove that tumor and really allowing us to free everything up. So this is my fellow and one of our former residents working, and really just kind of leveraging that tumor out of that area. And so you can see that it's relatively stuck, and I think others have talked about how the consistency of the tumor matters both in your resection, but also somewhat in your repair because of the defect that you're going to end up with. So if we move a little bit more forward, you can see again, we're taking out all of these different pieces, and there are a lot of different tissue attachments. We're clearing out some of the central component, and I'll skip forward a little bit beyond that resection. We've gotten out most of the tumor at this point, removing some of the last pieces and again, some of those fibrous attachments. You can see at this point, we have a pretty large CSF leak. So at this point, the tumor is out, and I believe that it will come up in a second to show you. Bipolar, something that's bleeding. So you can see that this is our opening, and then we need to make a good repair of this. We have our optic chiasm. Obviously, we have our ACA. We have the left and the right cavernous carotid that's exposed. And so when we do our repair, obviously we need to be thoughtful about how much pressure we're putting on that area, but we also want a good repair, and we want to fill that dead space and fill that area. So for us, usually we're going to do our skull base defect reconstruction using alloderm. And so this is a pretty large piece of alloderm, which is a radiated cadaver skin. And we'll frequently make that reconstruction somewhere around 3 times the size of the defect, maybe a little bit larger, depending on how much dead space we need to fill. And I won't make you meticulously watch us try to spread out this very large piece of alloderm, but one of the biggest components of this is making sure that we're really spreading everything out, and that we make it pretty clear that we don't have any folds or anything that's left in the center, so that we've got a nice open area. And I'll skip forward just a little bit. So again, kind of unfolding everything. One of the things that's really important is that once everything is unfolded, you should really be able to see that area of pulsation in the center. You want to be able to feel where all the bony edges are, and so you'll see my fellow start to do that in a second, where we're trying to locate where all of those bony edges are, because of course that's where we're going to now be putting our repair and our gel foam wrapped in Surgisil into that area. So once we have that all nicely kind of spread out, then we do this inlay onlay technique. So this is a little bit of gel foam wrapped in Surgisil. We usually size it kind of complementary to the defect that we have. And you'll see that slowly, as we keep filling this area, you'll start seeing pulsation. And you can see that now it makes sense why we had such a large alloderm to really be able to fill that area and that space. And this, you know, obviously takes a little bit of time at the end of the case to really make sure that you're paying attention, being thoughtful about the amount of tension you're putting on there. You don't want it overfilled. You also don't want it underfilled. We'll often get a nice repair like this, and then we'll have that hold up to Valsalva and do a couple tests to make sure that we really feel like this is a strong repair. One thing that you can see is that on the edges, the alloderm is folded over the bone, and now we're putting gel foam on those edges, essentially to hold that down and to make sure that as it heals, because this alloderm almost forms a matrix for the mucosa to regrow over, we want it to really incorporate and attach to the bone and the surrounding mucosa. Once we fill this whole area with gel foam also serves as a barrier between the packing that we're going to use and when we remove it, that way we're still leaving our repair in place. So this is a Miracell, which is permanent packing. We do need to remove this, usually dependent on the size of the defect. We'll remove it somewhere in a week to 2 weeks afterwards. We'll inflate that Miracell with some fluid so that it's nice and soft, and then we'll be able to use that to compress the area that we've done our repair on. And what you see is that once we inflate all of that, we'll check to make sure that it's pushed up against both sides of the repair. It sits essentially folded in that posterior septectomy, and that ends up being the repair that we leave in place, and patients stay on antibiotics during that time. And apparently I lost my, my last slide. So this is this patient's imaging post-op. I apologize, I couldn't find her MRI, but this is about 10 days post-op after we removed her Miracell. Her gel foam's still in place, so obviously it's filling a little bit of this area, but she had a nice repair. We didn't have any problems with the leak. And for most of these patients, that incorporation of the mucosa growing over the alloderm takes somewhere around 3 to 5 weeks, depending on the size of the defect. And our patients tend to do very well with this. So obviously there are lots of days to do the repair and to do it well. Any questions?
Thank you, Karina. Yeah, challenging case. I'd love to hear what the panel would do for somebody who has no nasal septal flaps, large defect. What are your strategies for a repair for these cases?
Tom Beaumont here. I've had a couple of these actually since I landed out here that have been operated in the community, and I have to go back, and we've done a couple things. The one that I like the most is a tunneled pericranial flap. So I do a bicoronal incision, elevate the galea and the soft tissue, and then basically pass a tunneled pericranial flap. That's if we're doing a draft or a transcrib approach for sinonasal malignancies. And that's worked very well for us. So that's what we've done on the ones that I've done most recently.
Are you able to get that all the way back into the sella and cover that type of a repair?
Yeah, actually, even with a draft 3 and a complete cellotomy all the way back for an esthesioneuroblastoma that basically has been nibbled on a couple times in the community, we're able to get that flap all the way back. It's actually very nice. You can make it as long as you want from the bicoronal. In fact, you can undermine posteriorly and you could make the flap twice the length, perhaps, from the frontal table to the sella.
Yeah, that's a nice alternative I use on when there's no other tissue to reconstruct, and I've had some failures. I think on a pituitary, such as the one that Dr. Levine showed, I'd probably do something very similar. I would use fat quite a bit for the sella, and even for the sphenoid, if needed, to bolster that up. I've done that sometimes, probably with a lumbar drain as a safeguard if I don't have a pedicle nasal septal flap. But I agree with Dr. Beaumont that we use pericranium for any failures on extended approaches as well.
Question for both of you about the use of alloderm. You know, there's always a discussion about, you know, using an allogenic devascularized tissue in the sella, and I've tried to get away from it completely. What has your experience been with infection using alloderm?
You don't really.
I haven't had any. Yeah, haven't had any.
I do every repair, every skull-based resection repair, patients who are radiated. I think almost all my partners do it that way. We have very low refection rates. We haven't really had a problem. Obviously, when I have packing, I'm putting in some type of antibiotic for that time frame. But once they're off of the packing, it's out, they're off the antibiotic. So we're not really seeing a lot of issues.
Great. I love the material. I use it for transcranial reconstructions all the time. I've just stayed away from using it for endonasal approaches.
Yeah, I go back and forth with the alloderm and fasciolata, depending on what if I need fat. Oh, sorry.
And I would say that, for example, for pituitary, especially for pituitary, when you have a small leakage and you don't want to use an nasoseptal flap, we use usually mucoperichondrium from middle turbinate, which seems to work quite well. If you want to avoid the nasoseptal flap for pituitary, seems to be a good alternative for that.
And for large openings where you don't have a flap, Dr. Cavallo, what do you guys use?
Yeah, pericranial flap, of course.
You can also get a decent flap off the inferior septum and floor, and even going under the inferior turbinate a little. That sometimes works just for a sellar procedure. It depends where you're trying to reconstruct, but there's often some residual tissue there that we can salvage.
Agree. Yeah, we've used that before as well. Okay, great case. Thank you, Karina. Thomas? You're muted, I think.
Can you see that?
Yeah, that looks good.
Okay, great. So again, thanks to Dr. Ivan, Dr. Morkos, Dr. Benjamin, and Dr. Komatar for inviting me. I feel really lucky to be here amongst the greats, you know, Dr. Cavallo, Dr. Dazada. It's a great opportunity for me. And so I have one case for you that I want to show you that was a bit challenging and has a little twist on it. This is a case of a craniopharyngioma that I'm going to show you today. And you know, just in this guise of the team effort, every case that I do here is along with my partner, Adam DeConde, and I've been very happy to find him, and together we've had a great experience so far. So this is a 64-year-old male who presented with 6 months of progressive vision loss. He ended up in an ophthalmologist's office and basically had those visual fields that led him to getting an MRI, and the MRI demonstrated this cystic solid craniopharyngioma. This is some additional preoperative workup that we got, and interestingly, he had this, what I believe to be based on the imaging characteristics, probably a calcification along the A1 on the left. And if you look at our preoperative navigation CTA, fortunately there wasn't an aneurysm associated with this craniopharyngioma, but also it demonstrated a couple other things. And one, you can see some of the mass effect on the ACAs and how high they are. Also, left side was dominant. Everything on this patient seemed to be dominant on the left. And this lower axial CTA is just to remind me to tell you that I couldn't appreciate pre-op a PCOM on the right, only on the left. He had a full endocrine workup, of course, and Besides low testosterone, his axis was functioning perfectly fine, with the exception of perhaps some stalk effect causing his prolactin to be elevated. And so we took him for endoscopic endonasal approach. We're taking the middle turb, nasoseptal flap, back here, large septectomy, exposing the skull base, drilling. And once we drill, we start to sort of eggshell and out fracture some of the bone. And that's kind of my goal, is to onion skin or eggshell most of it. Once we expose some of the dura, I use bipolar and take the intercavernous sinus, and then just gentle drilling. And again, the goal is this I kind of always took away from Danny, which was to whenever you can, onion skin and thin the bone so that it can just simply be out fractured like this, as you can see there with the middle clinoid. I also use the Kirsten to just gently out fracture. I don't like to use the punch. In fact, I'll never punch the bone. I just use it to out fracture. So we drill widely, out fracture all this bone, drill the planum. In this case, we needed to get anterior to the tumor, and so we drilled the planum quite anterior. Again, a little bit of bone that was heavy that I didn't want to push down, so I sort of drill it along the way, and then just out fracture all this bone gently and widely. Intercavernous sinus again with the bipolar. I'm not worried about the chiasm because I know it's up above superiorly. And then open the dura in standard fashion above the intercavernous sinus, as well as below the intercavernous sinus, trying not to get the gland because I know we have gland function preserved and it's right in this area. And, you know, classic move that has to be done, of course, bipolar and intercavernous sinus before we divide it. And gently work our way into the subdiaphragmatic space to isolate the gland with the hope here of finding the stalk. Again, my goal here is preservation of pituitary function. He came with it and I wanted him to leave with it. Of course, we're going to try to get all the tumor out as well. And we work along this plane carefully, bipolaring, removing the dura if we have to with a Kirsten punch. And the place where I start to identify the extracapsular plane the best was along the right side of the lesion. So we work along that right side, both bluntly and with simple bimanual dissection like we always do, sharp. Tumor was heavy, so I got into it a little bit here to do some internal debulking so I could manipulate the extracapsular space a little bit more. Here I was able to identify first the left optic nerve as well as the ACOM and get the idea that they were extremely adherent to one another, as we would have predicted from the preoperative scan. I went back over to that right extracapsular plane because it seemed to be the most advantageous, working below the right optic nerve, as you can see here. And we just gently start working along this plane, elevating the lesion, getting a feel for how it's adherent. We can see this communicator that I couldn't appreciate on the CTA there. And then we start working along this plane with blunt and sharp dissection, sharply dissecting all of these adhesions from the area of the PCOM and the brainstem perforators, and of course taking care not to get the perforators along the way. It was an extremely adherent tumor, as they often are. Worked our way back towards the infundibulum, again the communicator there, and the stalk right here, as you can see, coming off the infundibulum. And so in this way, we freed up a lot of that area of the tumor, debulked it, and then wanted to try to get this anterior portion off of the stalk. Again, once we appreciate it, we sharply dissect most of that free and continue working to free up as much of this sort of bulky tumor off the stalk as possible. Then kind of turned our attention over on the left side, where the tumor was kind of bulky and still stuck to the carotid. Much of the bulk material I just kind of rolled out there, and then took a look up here. This is that excrescence that we saw, that calcification. That's a microdoppler going up because I know there's an A1 in there. And we just started working, getting these sort of bulky structures off the optic nerve and the A1 behind to try to understand if we can open up this plane or not. It was extremely adherent at this point, and this was sort of my first idea that maybe I wasn't going to be able to get all of this capsule off. Again, sharp and blunt dissection, sharp dissection again of all this mass. And same back here until we sort of get as much of the bulky mass off of the optic nerves and that sort of soft tissue that's holding that the A1 is invested in. Same thing here. You can see the P1 back there, the PCOM here, and this membrane, while I could have opened into the posterior fossa here easily, I wasn't sure I was going to get it all off of the brainstem and the infundibulum. I left that then over towards the carotid. Try to understand how it's adherent. Sharp dissection off the carotid now with a 45-degree scope coming from beneath carotid here. And then we get most of this mass off of the carotid on that side. I go anterior to the lesion, open the planum now, trying again to get ahead of the membrane of the tumor. It was again adherent. We worked to try to get it free. And in the end, I decided around this point that I was going to probably have to leave some of this membrane. We worked on that for a while, took a quick peek at it up here again, and it was so invested here in the ACOM and the A1s. I decided not to risk sharply dissecting this, and I'd love to hear from the panelists on their thoughts about what they would have done here with the idea of cleaning up as much as I could at this juncture, preserving his pituitary, and moving on to radiation post-op. We irrigate. We use only collagen inlay. This is sort of in what Danny Prevedello and I, when I was his fellow, called the flower basket. We put a few pieces of gel foam in there to sort of imbricate it the same way Dr. Levine was describing and Dr. Cavallo talked about with fat. After that, then of course comes nasoseptal flap and some gel foam, and in this case, Vaseline gauze and Amerisol. So the patient did very well intraoperatively and postoperatively. His pituitary function was preserved. He had transient DI for about 48 hours. This is post-op scan. Gland looked fine here. Nasoseptal flap looked fine. You can see, of course, that membrane that I left up above enhancing, gland enhancing, chiasm coming down. So I was happy with that. He was discharged without any pituitary supplementation. He did develop mild adrenal insufficiency based on an AM cortisol about 2 months out, and currently continues on like 5 of prednisone. This was an adamantinomatous beta-catenin 1 mutant craniopharyngioma, so unfortunately that meant no pharmacologic options even on trial for him. We planned for RT. It was delayed 4 months because he was a very large guy who could never get comfortable, stagnant, and constantly asked us to stop the scans, so his RT was delayed. He had a cystic expansion, and much like Dr. Cavallo described, I thought about potentially placing an Ommaya, a stereotactic aspiration, etc. But his vision remained much better than pre-op. We decided to ride it out. He got 54 gray. About 6 months post-op, he completed it and eventually returned to work, was doing well, and has these visual fields at 1 year follow-up. So with that, I'll say thanks again for the invitation. I'm happy to take any questions if we have enough time. And also, I'm lucky to be able to work in such a wonderful place with all the technology that we have.
Great case, Tom. I'd love to hear some of the panelists' opinion on what to do in these difficult situations when you have calcification on the artery and very, very adherent craniopharyngioma.
No. Nice case, and I would use the same strategy you used. Very respective of the structure. No need to take a big risk around A1, A2. Radiotherapy was effective, so good strategy from my point. Good strategy.
I thought it was a great case, really nice outcome, Tom. You caught me with my foot in my mouth, because the only thing I would have considered in a really big guy with that much of an opening is an eyebrow cranie with that much anterior cranial fossa extension. I think it would have drastically reduce the risk of a leak, which you didn't get anyways, which is great. I would have been worried about that in a big guy. But that would have been the only other thing I would have considered on that case. But I think your decisions and your outcome were fantastic.
Thank you very much. I actually briefly discussed a transcranial approach with him. I honestly was still leaning more towards an endonasal. And it was interesting. He was all on for any endonasal approach, but he was very uncomfortable with the transcranial approach, which was interesting given the peril that, of course, you can encounter with the endonasal approaches. Yeah, you know, the trick with this case was, and I had been in touch and reached out to many folks, those cystic reaccumulations that you can get when there's a little bit of a membrane around can be really a challenging to manage, problem to manage. And I thought about aspirating Ommaya, even interferon, quite frankly, if he wasn't going to get his RT. And I'd be curious to hear anyone's experience with those.
Yeah, I mean,
Ommaya usually is effective just to take time to radiotherapy to become effective. We treated several patients with the Ommaya catheter, but almost never I made suction through the reservoir. It was just effective to deflate the cyst and to make communication of the cyst with basal cyst. That's probably the main purpose of this catheter, to make a
Dr. Cavallo, could I ask you, on the vein of Dr. Law's 97% indications for pituitaries, what, out of your 120 some cases, how many times do you think you've had to place an Ommaya, or what kind of percentage do you think in one's career they'd have to do something like that?
I would say we have used it in our series around 5-6 times.
Okay.
5-6 times. But
Great.
and in all the cases it was because recurrence. Except one case in patient with poor condition, to reduce intracranial pressure and to resolve hydrocephalus, because you have to consider also this, because there are patients in poor condition which cannot tolerate hours of transcranial or endonasal procedure. So it's a savage procedure. So it's also another option.
Yeah, I've had a couple cases with Ommayas, and there's a few reasons to place them, as Dr. Cavallo was saying. One is to decrease the cyst fluid and intermittently aspirate, which definitely temporizes some patients. And the other one is to treat with either interferon gamma or some other, p53, something like that, or p52. And so, for those cases, the idea of placing it early, I think, is questionable, because I've had a couple patients where you think you could predict which area would regrow or which cyst is going to form and become the issue, only to later find out that in fact it was another area and that cyst is stable. And then, so I've had a couple people come to me with Ommayas placed. They worked in 1 or 2 areas, and then what happens is that another cyst is up working, where they were placed during the time of surgery, and then you end up having now the cyst grow somewhere else, and now they have an Ommaya in an area where it's just scarred in, the cyst isn't growing, and yet you have to deal with a different area. And so the timing of the Ommaya, I think, is a whole nother discussion of when to do it and to why to do it. But yeah, great case. I echo Gabby that was a very challenging case, and I don't think anybody would start off with starting off with that with their first endoscopic case with calcifications and large patient, but your outcome was phenomenal. Any thoughts about using like propavrin when it's that stuck to the vessels, worried about vasospasm on the PCOM and the PCOM perforators laterally?
Yeah, we use it half and half.
Routinely after every major extended case like that? Gigi, you use it?
Almost every time we see some blood around the vessel, before we close, we wash with propavrin.
Yeah, we've only done that on a couple occasions. That's not my routine.
The efficacy is not proved, of course, but we find it useful. And also we use nimodipine in the post-op, nimodipine infusion for 3-4 days in high-risk case for the same reason.
Interesting.
Yeah, I've never used it for an endonasal case, but I routinely will use it, particularly for frontoinsular tumors when you have MCA branches that you've been manipulating all day long, and they look a little bit, you know, a little bit spastic at the end of the case and stenotic. I'll use it then, and you get a nice response from it.
Yeah.
Omayas, I steer clear of at all costs unless it's just one of those cysts that's rapidly and frequently reoccurring. Because as you know, the Omaya itself will become very adherent to the capsule as well.
Yeah, through the fenestrations and everything. And I think to Dr. Ivan's point, I love hearing everybody say, don't do it, because I thought so. I really thought long and hard about it. And in each interval MRI, I sort of, my hand got closer. But the other, to Dr. Ivan's point is, as I looked at the cyst that was developing, it was unclear how it was communicating. So the question was, where do you put it? And he already had probably an 80% recovery of his vision. And so the question was, is what am I trying to get out of it, other than to make the scan look better and perhaps make me sleep better at night? You know?
Yeah.
You know, what you can do when you put a Maya reservoir, a catheter, you can put under endoscopic vision, and we do double fenestration of the cyst with the ventricle and with basal cyst. And why to leave the catheter is because if you have to redo surgery, you can follow the catheter and you have a sort of guide to remove it. So it's a sort of guide, okay? But it's very important to do a double fenestration of the cyst with the ventricle and with the basal cyst to avoid that it close and re-expand again.
Okay, Dr. Hamp, are you online?
Yes, can you guys hear me?
Yeah, can you, should I share your slides here?
Sure. Yeah, I mean, I could do it from here, but if it's easier for you, that's great.
Sure.
Well, Mike, thanks so much for having me. This is obviously an incredible panel here. Very humbled to be in the mix. And I have to apologize for my webcam dysfunctionality here. I just actually joined Westchester Medical Center a few weeks ago, and I'm not full throttle yet on all the technology here, so will be soon. I think that this case is a little bit of, there are two aspects of this case that I'd really like to get Dr. Cavallo's input and the panelists. One aspect of it, obviously, is the fact that it's a functioning tumor and kind of how you guys like to handle these and kind of what your goals are surgically. And the other is, you know, the feared carotid injury and kind of how, you know, we manage that in this case and what unfolded. So very quickly, because I know we're late here, this is a 51-year-old who actually went to a new primary care doctor who herself, she picked up some acromegalic features and went ahead and ordered an IGF-1. It was extremely elevated. I think this is probably the highest number I've ever seen. It was over 1,000. And so then she went ahead and ordered an MRI of the brain pituitary protocol and found this intracellular mass. And you can see on the coronal there, there's obvious cavernous sinus involvement. And so the decision was made to take him to surgery. We can go to the next slide. And, you know, I guess the first question would be, you know, for you, Dr. Cavallo, and whoever else wants to chime in, when you know that there's that much cavernous sinus involvement of a functioning tumor, I know this is a question that we've asked many times over, but, you know, is your belief that you can achieve, is it realistic to think that you can achieve a surgical cure of this kind of patient and this kind of tumor? And, you know, how aggressive are you in terms of going into the cavernous sinus? If it's just kind of naturally done in terms of following the tumor into the cavernous sinus, is that what you do? Do you open it intentionally with the goal of removing it? How is your, you know, what's your kind of paradigm for that?
I would often try to follow it into the cavernous sinus with an angled scope. And in this case, this one's, I think from looking at it, it wraps around anteriorly, more of a KNOS 3B type pattern of invasion. So yeah, you know, a lot of this depends on the consistency of the tumor. A soft tumor can be suctioned out of the cavernous sinus. you don't want to be doing sharp dissection on the carotid to try to peel a firm tumor off. So I will follow it in, occasionally a medial cavernous sinus wall resection if needed. But with acromegaly, to answer one of your questions, what's the potential of it being curative? With an IGF-1 that high and invasive tumor, statistically it's low. I would still try to resect as much as possible, but you have so many good options for medical therapy and radiation therapy as well that I think you have to gauge how safe it is to resect that part around the carotid.
Yeah, that was very much our mentality going in. I think the likelihood of getting something curative in that kind of a tumor, the level of invasiveness and just how high the IGF-1 was low. So yeah, I don't have footage of this, probably in a way better not to relive some of this, but when we opened, we had very immediate, as you'd expect, expression of tumor contents under pressure. And after we got through a very superficial, just kind of grasping or removal, there was quite a bit of bleeding off to the left, a little bit more than you'd expect. We were able to get control pretty rapidly with some gel foam, cottonoids, and just pressure. And then we reassessed, and it appeared to me that we were probably too lateral, that we had opened up over the cavernous sinus unintentionally. And so we just recalibrated, opened the dura more centrally and to the right, and then had a real obvious expression of tumor that to me confirmed that we were intracellular at that point and might have actually traversed into the cavernous sinus on the left initially. And so I completely debulked the cellular region, and then there was this, you know, as you can encounter in these kinds of cases, membranes within the tumor, and I was unsure if this was actually one of these kinds of membranes within the tumor or whether or not it was actually the cavernous sinus wall. And I ultimately determined that it probably was the actual wall itself. And so at this point, I said to myself, we were already in the cavernous sinus to the left. It's a fairly young guy. Is it worth just re-exploring the cavernous sinus, see if we can get a little bit more of that tumor out? Wondering what the panelists would have done at that stage, or would you have just let that sleeping dog lie? And would you have taken the cavernous sinus wall, which I'll show you on the post-op, looks like it may actually be invaded with tumor, and it looked to us like that, like it may have been endoscopically. So just wondering kind of at that juncture what people would have done there.
Yeah, Simon Jacques here, he's young. Yeah, I would go for maximal surgical resection that you can achieve, curative or not. I think his chances are best with you know, maximum resection you could achieve. And, you know, instead of, I guess, waiting for the carotid to show up, you know, the use of that micro Doppler is very handy in kind of even Dopplering through the tumor. So it gives you a little more, you know, assurance, or gives you an idea where it is. Then you can adjust moves. That's how I would handle it.
Yeah. Yeah, we did bring in the Doppler, and that I should have mentioned that earlier. We brought in the Doppler kind of after the bleeding had stopped, and that's what kind of made me confident that we were in the cavernous sinus there. But I brought it in again at this point as well. I mean, the decision I made was along the lines of what you recommended. I said, look, we were already in the cavernous sinus, wasn't my intention. The bleeding's under control. So then as I just started re-exploring it, then we just got into massive bleeding. I mean, it was with minimum manipulation. So clearly I'd opened up whatever had kind of walled off at that point. And so, you know,
you mean venous, Simon, or arterial?
No, it was arterial. It was arterial. And so I was able to, with pressure and gel foam, we'll see on the next slide, just kind of the very basic stuff I did to staunch it in a way that made me think it was venous, but there, when I peeled back the layers of the foam and the cotton, it was clearly squirting under high pressure. There's no question about it. But I was able to get control initially. I was able to alert anesthesia. He actually got hemodynamically unstable fairly rapidly. It was almost out of proportion to the blood loss, I thought. But it allowed us some time. And so I'm just wondering, you know, what do the panelists do in this situation? How many of you encountered? Because this is the only one that I've dealt with, albeit it was recent. and just kind of, you know, what's your paradigm? What list of steps do you go through in this kind of panicky situation?
Well, I think you did everything right. I think, I mean, with a severe acromegalic patient, before I forget, that that discrepancy may be explained by some type of cardiomyopathy.
Great point. Yeah.
But initial control with cottonoids of an injury, get anesthesia involved, and then get the muscle patch and hold it up there, and then decide on how you want to do your closure and go to the endovascular suite, and then you can make some decisions about how you want to proceed. But crushed muscle is the way to go, and it sounds like you did everything right there.
And Simon, also a warning to the young folks listening in: well, the one thing you don't want to do, and obviously you didn't do it, is inject powder gel foam. I mean, you know, people may, you know, the importance of recognizing arterial versus venous. Obviously, casting gel foam up the arterial tree, very, you know, muscle works best, and pressure. I agree.
Yeah. What
Simon,
about?
sorry,
we heard from the temporalis. Was just wondering what you guys thought about that, Tom, or if you guys go abdominal on that.
Simon, it's Tom Beaumont here. I'll use that as a chance to chime in. We had one in fellowship that I was intimately involved in that we knew was going to happen. That was a twice operated post proton beam skull base, and so in that case, I think we addressed it kind of the same way you would. And as Dr. Zada said, I mean, with the standard techniques. In terms of muscle, I think anytime I'm going to go in the cavernous sinus or I'm doing any kind of high risk manipulations of neurovascular structures, I prep the leg. I picked that up from Ricardo Corral, and you know, you just prep the leg, because the worst case scenario is you don't need it. And I take muscle from the leg if I need it, which is what we did with the one that I've been involved in my career so far.
And by the way, you would be joining excellent ranks of Norman Dott in 1932, who used muscle to stop some, you know, that first aneurysm bleeding that he encountered, and it worked.
Yeah. And the other thing is, I would definitely get a formal angiogram after that.
Agreed. Yeah, unless it's a pinpoint, unless it's a very pinpoint injury that's very tiny and you get really good coverage, and there's a very low propensity for a pseudo aneurysm to form. We followed a couple of those with CTAs, but any significant injury to the carotid should get a formal angiogram, and a delayed one as well.
I have just one question. When you were able to visualize the injury on the carotid, do you think maybe that you avulsed a small hypophyseal perforator, or was it actually a laceration to the externa of the vessel?
Yeah, it's a really good question. I was just getting very small pieces, and it just seemed to me it was probably on the carotid itself, because just whenever we peeked under the cottons, it was just coming out so under such pressure. But it is hard to say for sure. It could have been an avulsed hypophyseal infralateral trunk. It's just tough to say for sure. But ultimately, you know, it just we were able to slide the muscle as we lifted the cotton patty, and then just progressively peeled the patties off after applying the muscle under pressure, and it had stopped. What we did for him was we finished up, we took him down for a CT angio, which looked totally fine, and kind of to the point of it being maybe just a pinpoint leak, so, you know, pinpoint laceration there. That's why we did that. We extubated him, he was totally fine. He did have a 6th nerve palsy. We could look at the next slide to just see kind of what the post looked like. The vascular imaging, there was nothing of significance. But you can see, I'm personally not really accustomed to clearing that much out of the cavernous sinus. And so that's why I just kind of labeled it that way. You know, we ended up doing a CT angio just in delayed fashion, and it was fine. He left the hospital in 3 days. The 6th nerve palsy improved considerably by the time I saw him in the office 2 weeks later. And then 6 weeks later, the IGF-1 had come down to 510. So, you know, you could see the thickening there of the cavernous sinus wall. It didn't really look like there was much residual anywhere else. I mean, the carotid looked fairly skeletonized. And you know, and that's, we had kind of already addressed this a little bit earlier in terms of radiation options and medical therapy, but that's how, you know, we're going to go down that road.
Simon, of course, you'll need to do a delayed angiogram, actually a few months post-op.
Yeah.
You know, there's a nice paper by the Pittsburgh group, I think, reviewing their 9 carotid injuries endoscopically and importance of pseudoaneurysm formation. Another trick I learned through mostly cerebrovascular surgery more than skull base is adenosine. When, you know, you get torrential arterial injury, you can't see a thing. The minute you lift something, you know, 30 milligram adenosine, hopefully just will stop the heart 10, 15 seconds, just so you can actually assess how big is the injury. Then, you know what I mean? If it's a pinhole versus, it's so handy, besides aneurysm surgery, but arterial injury during skull-base tumors, I find it very useful. Hopefully not very frequent, but very useful.
Yeah, I would say, just having gone through this, I would say that opportunity to visualize the source, though it's so, you know, it's so frightening to try to actually lift up this after you get control, to go back in and try to, it's just so critical. It's kind of not what you want to do, but you almost got to take the plunge, because otherwise they're just these blind insertions of gel foams and the muscle graft, and you just, if you don't get it really on that site, it's ineffective. So I can see why adenosine, just, you know, giving you that small window would be a good adjunct.
Okay, well, thanks for sharing. I'm glad that there was a good outcome there, Simon. So well done with handling that tough situation. If anybody hasn't been to Dr. Zada's virtual experience of carotid bleeding endoscopically at one of the courses or meetings, I encourage the next time we're able to see each other in person that you find him and go through his model, because it is definitely one of the most realistic experiences you can get without doing it yourself. So thanks, Gabe, for putting that together. Dr. Cavallo, thank you so much for staying with us till tomorrow. And all the other panelists, we really appreciate it. I hope everybody stays safe, and we'll see you here next week.
Great to see you all. Thanks for
Bye,
having
all. Bye, Luigi.
Bye, Jacques. Bye, everybody. Gabby.
Nice to see you. Bye, Josh. Bye,
Thank you very much. Appreciate it.
Thanks.
Thank you again.
See you
Thank
guys.
you for everything. Bye-bye.
Bye.